Back to our today's class. Can you please confirm that you can see my screen? Excellent. So let's do this. So today we have to finish up the general pharmacology chapter. I'm not all of the pharmacology, just the general stuff. So yesterday we were speaking about the pharmacokinetic. Remember, pharmacokinetic, it's everything since the moment of administration to the metabolism to what the drug actually do until it's cleared out from the body. Okay? While the pharmacodynamic is what is the effect? I mean, how does the drug act on its receptor? Is it M1 receptor? Is it beta 2 receptor? That's more of pharmacodynamic. So we had left the dosage calculation. So to calculate the dosage, there is something called the loading dose and something called the maintenance dose. Let's say I have this patient and I want to load a drug inside of his body. So of course you want to reach a number in which you know this is the efficacy you want. This is your Vmax. Okay, that's what you want to reach. So for the sake of reaching it, you need to give the loading dose. So the loading dose let's say that this is the dose you want to reach. This is your goal. This is your target. And for the sake of reaching that, you need your loading dose. So you are increasing until you reach your target. So there is something called C p, okay? This is your target, okay? So when you reach your target, that's it. What you have to do now, you need to start the maintenance dose, which is keeping it at the exact same number. Okay, or to be more truthful, keep it in the exact same range, because during the day the drug increases and decreasing. We urinate, it gets out. We take another dose, it goes in, and like that. But we keep it within the basically the range of the target dose. So the loading dose is equal to the following. They write it's equal to the target, little b for plasma, target plasma concentration multiplied by the volume of distribution, which was represented on which tissue does the drug goes to. For example, if we have a really low volume of distribution, it's stuck into the vascular compartment because it's bound to the albumin. But if we have really high volume of distribution, it means that it can pass all of the barriers and it can even reach the brain. So remember, the best type of molecule that can go everywhere, it must be small and it must be lipophilic. Okay, lipophilic. So the next thing we have here, so yeah, the target dose multiplied by the VD divided by F. So F is the bioavailability, and the bioavailability in case of IV administration is how much? It's 100%. It's 100%. Yes, so 100%, which is equal to 1. Okay? So maintenance dose, however, is the target dose multiplied by the clearance, how much is going out from my body, multiplied by the interval. Because I told you, during the day, you clear a little bit, you take one more dose, clear, one more dose, clear, one more dose. So the clearance should be taken into consideration, and the target interval should be also taken into consideration. And all of that is divided by, again, the bioavailability, which is 1 in case of IV administration of a drug. Is it important to know the formulas? The answer is sadly yes. Even you must calculate them during the test. They will give you everything, and you have to calculate the loading dose and the maintenance dose. You also have to know what things can affect them. For example, if you have renal or liver disease, the maintenance dose will decrease, and the loading dose is usually unchanged. Let's try to understand what they say. Well, the kidney and the liver are responsible for clearance, right? They are responsible for clearance. So since the liver and the kidney are responsible for the clearance of the medication, a disorders in them are going to decrease the maintenance dose. Why? Because the drug is stuck into the body. It's not getting cleared out. If you cannot clear out the drug, it will stuck into your body. Okay, so why it's not affecting the loading dose? Take a look at the formula of the loading dose. It does not have a clearance in it. So clearance does not affect the loading dose. It only affects the maintenance dose. And that's why they write here. In the maintenance dose, it's low, while in the loading dose, it's untouched. Time to steady state depends primarily on the half-life and is independent of dose and dosing frequency. So again, what is a steady state? Steady state is the, well, loading dose. We have reached the what? The maintenance dose. Steady state is when you have the exact amount of the drug inside of your body. It's, as we said before, it's depending on the half-life. It doesn't matter. You go up or you go down. It's always dependent on the half-life. So this is it for pharmacokinetic. Well, not really. All of that was about just like putting the drug in. Now we'll speak about the drug metabolism, which is the second portion of the pharmacokinetic. We have absorbed the drug, it went inside of our veins, or we took it orally, it got absorbed, it went to the portal circulation, and after that it's in the liver. In the liver, we have a system called cytochrome B450. Does anybody remember where is cytochrome B450 in the liver located? I mean, which zone? Yes, that's correct. It's zone 3. So the cytochrome B450 is located within the zone 3. And they write here that geriatric patient loses phase 1. First, yeah, basically the cytochrome B450 is a really big molecule that it has so many biochemical reaction happening inside of it. It has two main phases, phase 1 and phase 2. Okay, so geriatric patient lose phase 1 first. Patients who are slow acelerators have an increased side effects from certain drugs such as isoniazid because of a decreased rate of metabolism. So they cannot metabolize the drug as fast, which means the drug is going to be stuck into their body for a really long time. Let's imagine that this is the liver. I try to put isoniazid in it, right? So, well, it's going in, and for the sake of creating, well, you need to destroy a little bit of it to make an active portion and the portion that is going to be trashed. But here, because of a low rate of metabolism, you just accumulate the isoniazid inside of the body. Why? Because you are not metabolizing it fast. Because of that, it's just going to accumulate, and lead to decreased rate of metabolism and a lot of side effects because of an increased bioavailability of the isoniazid. As I said, the drug has two phases. So they write lipophilic drug, which is going to the liver, has phase 1 and phase 2. So there is a chemical formula that said like ROH. I don't know if you know what that is. But if you don't know what that is, there is, well, a mnemonic. It's called rug on hair. Okay, or whatever you want, rug on hair. So reduction, oxidation, and hydrolysis. You just need to know the names. You don't have to know the exact same, what they do exactly. You just have to know the name. Reduction, oxidation, and reaction, ROH, ride on hair. So after they go through this process, initially they will lipophilic, right? Lipophilic means that they can go inside of the cells, they can penetrate the blood-brain barrier, they can go like through a lot of tissues. Now they become polar. Polar means water-soluble metabolite, and that means it's more difficult for them to penetrate the blood-brain barrier. But this is a good thing. Why? Because water-soluble means it can go to the kidney. It can go to the kidney, which means it can be cleared. So it's one of the mechanisms created to help in the clearance of the substance. Now we speak about lipophilic. Lipophilic drugs can also undergo phase 2. There is many of these. I'm not going to lie at you guys. It's irrelevant. The only one that is important is this one and this one. The other one are just not important. While these three, you must know ROH, reduction, oxidation, and reaction, to be in the phase 1. Sulfation and methylation are not really useful to know, but like the glucuronidation reaction, which is mediated by the UDP glucuronide transferase, is important because it helps us to metabolize which substance, please? Which substance? The glucuronidation process. Bilirubin. Remember, UDP glucuronide transferase help to convert indirect bilirubin into direct bilirubin, indirect bilirubin into direct bilirubin. And the acetylation is important for isoniazid, which is a TB drug. So that makes them very polar metabolite, except for acetylation, acetylated metabolite, which actually are going to become vice versa, less polar. Okay, good. So in general, the main idea of the cytochrome B450 is to metabolize the drug, which going to end up of making the drug either less toxic, more toxic, or going to remove them, help in getting them out from the body by changing their polarity. Well, what do I mean activating a drug? Well, sometimes when we give a drug, it's totally inactive until it reaches the liver, which is actually something good. But in the same time, aflatoxin, for example, maybe you know about that. It comes from the aspergillus. It's inactive until the moment it reaches the liver activates it, and that becomes cancerogenic. So what I'm trying to say here, that the cytochrome B450 just always convert one thing to another thing. Sometimes it's a good thing, sometimes it's a bad thing. If the process happens slowly, the amount of the substance inside of your body is going to increase. If the process happens fast, the substance is going to become water soluble much more faster, which is going to eventually clear it out from the body much more faster. What I'm trying to say, that when the cytochrome B450 is working really fast, the amount of substance inside of your body is going to be decreased because it's going to be cleared faster. And when the cytochrome B450 is decreased in activity, the substance is going to stay inside of your body for a longer period of time until it gets metabolized, which means you are going to get toxicity from the drug. So inhibitors of the cytochrome B450 can lead to toxicity, while stimulator of the stimulator of the cytochrome B450 can lead for the drug not even reaching his Vmax because it will be cleared out really quick. So the next topic is about the elimination of the drug. For the elimination, we have, we absorb the drug, we metabolize the drug, now we have to eliminate it, get it out of the body. There is two ways of elimination. The first one is called the zero-order kinetic, and the second one is called first-order kinetic. The zero-order kinetic, basically, there will be constant amount that will be lost. This is important because, for example, I'm losing 1 milligram per hour. Well, what about if I have 1,000 milligram in my body? You lose 1 milligrams per hour. What if I have 100,000 milligram in my body? You still lose 1 milligrams per hour. So you are losing a constant amount. It's not a percentage. So here, 1 milligram you are losing per hour, for example. Well, the first order kinetic, F for a fraction, so you are losing a percentage. You are losing 1% per hour. So what about if I have 1,000 in my body? You will lose 1% per hour, which is 10 milligrams, right? Let's say 1%. So for example, if you have 100 in your body, 100 milligram, you are going to lose 1 milligram. If you have 1,000, 10 milligrams. If you have 10,000, you are going to lose 100, and like this. So the idea that you are losing a fraction, that's the main thing. Okay, zero order elimination, which you are losing a constant amount per hour. It is going to be only 3 drugs you must know about. So a rate of elimination is constant regardless of the target concentration. So constant, I mean the amount of the drug in the plasma. So constant amount of the drug elimination per unit time. So the amount of the drug inside of the plasma is going to decrease linearly with time, as you can see here, because we are losing just 1 milligram, for example, per hour, or here they make it 2 unit per hour, but it's constant. You know, it's not a percentage. It's not a percentage. So you are losing these guys. So as you can see, the half-life here are totally variable. The half-life, in which how much it took the drug to decrease by the half, is variable. See? So each time it's less and less. Why? Because, well, basically in the zero order kinetic, it's a constant amount. So when the number goes down, the constant amount is going to be considered the higher number. So examples of this drug include the BIA. This one. I hope you know what that is. It's like this food thing. Just let me hold this away from here. Oh, there's a way actually to hide it. Oh yeah, good. Yeah, this guy. Okay, so what they are speaking about, the B are the three things: phenothiane, ethanol, and aspirin. Ethanol is a drinkable alcohol, methanol is the antiseptic, and ethylene glycol is the antifreeze. They always ask you to differentiate between these. The methanol can lead to blindness. The ethylene glycol, the antifreeze, can lead to kidney stones. And does anybody remember the ethylene glycol, which type of kidney stones it can lead to? Excellent. It is the calcium oxalate. Okay, good. So phenothiane, ethanol, and aspirin, yeah, they have zero order kinetic. So because they have zero order kinetic, that means that they are going to have a linear form of elimination. This is important. They do show you a picture of this, and they do ask you which drug do you think it is. You have to know the BIA. Or they can show you this, and they literally just hide everything, but they show you that the half-life are different from each other, which means it's zero order kinetic. Okay, the first order kinetic, however, they write rate of first order elimination is directly proportional to the drug concentration. If you have 100,000, the government is going to take 10%. If you have 1,000, the government is going to take 10%. So the more you have, the same percentage the government is going to take, but the amount is more. For example, let's say you make $10,000 per month. The government is going to take 10%, so she's going to take 1,000. Let's say you make $100,000 per month. The government is going to take 10,000. So the concentration, the fraction is still the same, but the amount is increasing. So the higher the amount, the higher the amount taken from you, but the same fraction. So rate of first order elimination is directly proportional to the drug concentration, i.e. constant fraction of a drug eliminated per unit time, which means like 10% per hour, or for example 50% per day. Okay, so the amount of the drug in the plasma decrease exponentially with time. Applies to most drugs. Most of the other drugs that are not PIA goes something like this. They do not have linear type of decrease, elimination. It's curved, right? And if you focus on the half-life, they are exactly the same, which is different from the zero order kinetic, in which the half-life were decreasing. So in the first order kinetic, it's a fraction lost, and the half-life will be exactly the same, as you can see, exactly the same. So it was 4 after the first half-life, 2, 1, 0.5. Okay, so that's the main difference between zero and first order kinetic. You need to know which one will lose a constant amount versus which one is going to lose a fraction. A constant amount means like an actual milligram, so something countable, like touchable. It's not a percentage. But in the first order elimination, it's a fraction. It is percentage. Okay, so now the next thing is the urine pH and the drug elimination. How can we trap the drug to exit our body? So this whole concept created here, it's actually super useful because it actually helps us to understand what we are speaking about. And how does the elimination from our body occur? So the urine pH and the drug elimination. So if we are speaking about the urine pH, we are going to have something like this. Ionized species are trapped in the urine and cleared quickly. Neutral forms can be reabsorbed. So if they have an ion and they are in the tubules, okay, so this is the molecule. It has an ion on it, which is free electrons. It is too big. It cannot penetrate the nephron tubule, so it will exit from the body. And that will increase its clearance. So the more polar the drug, the more chance is going to be excreted. Remember, that was one of the function of the cytochrome B450, to make the drug more polar, to allow it to become more water soluble, to allow it to exit from our body. So we have the weak acids and the weak bases. Do not look at this for now. The pKa, we'll speak about it when we reach it. Now just focus at the weak acids and the weak bases. An acid is defined as anything less, in chemistry, anything less than 7, okay? pH. If it's more than 7, it's high pH. Do not confuse this with the blood pH. Blood pH normal is 7.35 until 4.5, right? But that's the blood, that's not chemistry. So the weak acids include the following examples: acetyl salicylic acid, which is aspirin, methotrexate, and phenobarbital, which is a barbityrate. It's a drug that basically works on the chloride channel, which are basically GABA mediated chloride channel, and he makes the channel open for a longer period of time, so he increased the duration of opening of the chloride channel, which is going to more relaxation. So methotrexate is basically used as an anti-cancer drug. It's also used for ectopic pregnancy. And aspirin, acetyl salicylic acid, you know what is it used for. So all of these are acid. They are trapped in a basic environment. Okay, but trapped in the basic environment. Yes, well, that sounds useful. Why it will be useful? Well, let's say that you have a patient with methotrexate toxicity, and we want to get rid of the methotrexate, because otherwise they are going to kill the patient. If you have too much methotrexate inside of your body, this is highly toxic. So you need to get rid of it. The easy way to get rid of it is to alkalinize the urine. When the urine is alkaline, the weak acid is going to be stuck into it, and that will allow you to get him outside of the body. So treat overdose with sodium bicarbonate to alkalinizes the urine. So you give sodium bicarbonate inside of the urine. So the urine will become highly what? Alkaline. When the urine is alkaline, inside of the urine you have a lot of alkalinity, which is this guy, right? You are going to trap who? This guy, the acid. And that will allow the substance to get out from your body. So you trap it and it goes out. Okay, now the weak bases. The weak bases examples, it goes as follow. The TCAs and amphetamines. I have to say, TCA is a really bad example because it's not why we use the drug, okay? So it's not why we acidify the urine, I mean. So for weak base, if you want to get them outside of your body, a weak base, what should you do? Should you acidify or alkaline, make the urine more alkaline to get it out of the body? Again, my question, for weak bases, what should you do for the urine to get the drug out? So for weak base, for the sake of getting the drug outside of your body, you must make the urine more acid, okay? So if you want to get a base outside of your body, make the urine more acid. if you want to take an acid outside of your body, make the urine more base, it gets trapped, it gets out. Examples include TCAs, tricyclic antidepressants, and amphetamines. They are trapped in an acidic environment, and the treatment of overdose goes with something called ammonium chloride, which is basically help in acidifying the urine. Okay, I acidified the urine. So now anytime you are going to give a drug that is an acid, a base, it's going to be trapped with the acid, which is the basically the what? It is this guy, the ammonium chloride, right? So the ammonium chloride will help stuck to the base and gets it out from the body. Okay, so that is the deal. We're trapping it out and it goes outside of the body. But here there is a mistake actually in the book. The TCAs, it's not because we acidify the urine, we use that. It's actually incorrect. They write here the following. You must master this point. TCA toxicity is generally treated with sodium bicarbonate. You are like, wait a second. Sodium bicarbonate, it's a bicarbonate. So bicarbonate is an acid or a base. Sodium bicarbonate, acid or a base? So sodium bicarbonate is actually a base, okay? So because sodium bicarbonate is actually a base, it does not make sense we are using it with a weak base. But it does. But it's not for the elimination, okay? So we use for TCA toxicity sodium bicarbonate to overcome the sodium channel blocking activity of the TCAs. So the TCA tricyclic antidepressant mainly kill the patient from the toxicity by causing arrhythmia in the heart, okay? They causes arrhythmia in the heart. So by using sodium bicarbonate, the sodium bicarbonate is going to bind to the sodium channel in the heart, which will prevent the arrhythmia from occurring as a consequence of the TCA's toxicity. But there is no acceleration of the drug elimination. How come? Well, it's sodium bicarbonate, which is alkaline, and it's working in a weak base, which is the TCA, which is also alkaline. So that does not help in the accelerating in the drug elimination. Vice versa, it's decreasing the elimination. However, it's preventing the thing that is leading to the fatality, which is basically the arrhythmia. Okay, good. So the next point is the pKa. pKa tend to be really confusing topic for many students, but I will try to make it as simple as possible. Remember when we said that the pH, when it's higher than 7, we say, oh, it's acidic. When it's lower than 7, we say, oh, it's, When it's higher than 7, we say it's alkaline, it's basic. When it's lower than 7, we say it's an acidic, right? The exact same, the only difference that this is a pH with some form of a logarithm thing. You don't have to know it, it's just an equation. But basically, instead of 7, it's 9.2 for normal, okay? So if we are speaking about the pKa, the norm is 9.2. That's a neutral there. And if it's more than that, it becomes more basic. If it's less than that, it becomes more acidic. So just think about it exactly as you think about the pH. So the pKa is the pH at which drugs, weak acid or bases, are 50% ionized and 50% non-ionized. The pKa represents the strength of the weak acid or base. So let's try to think about this. They write here, so ionized species formation. Okay, so if you take a look here at a more basic type of environment, you have less ionized form of the base, right? Well, what I want you to know, the more ionized form you have, I will make it like this. Ionized, no work, it does not work, okay? Non-ionized, the drug is working, okay? Notice, at a more basic environment, just a second. Yes, at a more basic environment, we have less ionized basic molecule, right? Why? As you can see, it's going down, which means that the weak bases are what? Are less ionized, which means more functional. The more ionization, the less functionality. While the weak acid are highly ionized, which means they will be cleared outside of the body. And vice versa when the peak Ka is less than 9.2. Okay? So that's more than 9.2 and this is less than 9.2. So okay, when it's less than 9.2, as I said previously, everything is going to reverse. That's it. Okay guys, let's take a 10 minutes break and I will see you guys after the break. Okay guys, welcome back. So let's keep doing this. Just want to make sure, can you see my screen please? Can you see my screen? You cannot see my screen? Okay, so let's continue. We have efficacy versus potency. We have something called the Vmax, and we need to appreciate and understand what does it mean. Remember, the Vmax was directly proportional to the concentration of the enzyme, and it meant how much efficacy or what is the maximal effect that the drug can reach, while potency meant how much of the drug is needed to start making a pharmaceutical effect. So if I make something like this, actually no need, it's already here. So the higher amount here for drug A versus drug B, you can see that on the y-axis, the maximal effect of a drug A is much higher than the maximal effect of a drug B. So the Vmax of a drug A is much higher than the effect of a drug B. Efficacy is not the same as potency. Actually, they are totally different. And in the end, after I explain both of these, I will be drawing stuff for you and you must tell me, is this a drug more infectious or is it more potent? Again, when we are discussing the Vmax, we only look at the y-axis. So if I make something like this is a drug C. C is more infectious than a drug A and B. Okay. Efficacy, maximal effect a drug can produce, represented by the Y value of y-axis, basically, the Vmax. So increasing the Y value increases the Vmax, which means more efficacy. It's unrelated to the potency. Efficacious drug can be high potent, more potent or low potent. Partial agonists have less efficacy than full agonists because they are partial. So few things, I hope it's not here. I will remind me please to explain for you what is an inverse agonist. I will explain it after finishing these 2 points. So as you can see, drug A is much more infectious than a drug B, and the drug, let's say drug D, is the least infectious between them all because he has the least value on the y-axis. So efficacy, it's all about the y-axis, while potency is all about the x-axis. Okay, potency, the amount of the drug needed for a given effect. How much of the drug is needed to start have a pharmaceutical effect of the drug? It's represented by the x value, okay? So by the x value, left shifting equal to decrease in the effect in the x value, which means high potency. Let me explain. The more you go to the left, it means less amount of the drug are required to reach a pharmaceutical effect. So let's say you start having a pharmaceutical effect at 50. right? So for a drug A, you need less drug to reach this efficacy. Sorry, to reach this effect, not efficacy. Efficacy is different. While for the drug B, you need much more a drug to reach the same effect. That means a drug B tend to have much lower potency than a drug A. Drug A, because it needs less drug, it has much higher potency. So it's unrelated to efficacy. Potent drug can have high or low efficacy. So let's me try to draw this, and you must help me. So if I make something like this, this is a drug A, and this is a drug B. Which one between these two have higher efficacy? Which one between the two drugs have higher efficacy? Is it a drug A or is it a drug B? Well, I hope you are thinking that since drug B has much higher Vmax, right? He has had much higher Vmax, that will make him more infectious. Okay, which one is more potent? Which one is more potent? Well, for a drug A to start exerting a pharmaceutical effect, it's requiring less drug, while for a drug B, it needs plenty of a drug. So drug A obviously is much more potent than drug B. Let me give one more example. A drug A and a drug B. Which one is more infectious? Well, the more infectious will be the one with the highest Vmax, so it will be drug A, while the more potent will be the one that needs less drug to start an effect, which is also drug A. So drug A is more infectious and more potent. Okie dokie. Okay, good. So that's efficacy versus potency. Now we are going to start speaking about receptor binding. So receptor binding, we are going to speak what is this competitive antagonist, non-competitive antagonist, and a partial agonist. And also I will be explaining here for you an inverse agonist and what does it mean. So receptor binding. Remember, when we are speaking about a receptor, it's working at some tissue to exert an effect, right? So receptor binding, here you can see the two, like the agonist and the agonist with a competitive antagonist. He's shifting to the right. Shifting to the right means that he's having much, he needs much more of the agonist to exert the same effect, which make him having much less potency. However, the efficacy is still the same because the Vmax is still the same. So the Vmax is still the same, meaning that the efficacy is untouched in case of competitive antagonist. But if we speak about the potency, as you can see, because of the shift on the x-axis, the potency is much lower. So competitive antagonist, potency is low, efficacy is not changed. Why? Because Vmax is the same. It can be overcome by increased agonist concentration. So if you give enough of the agonist, eventually, as you can see, the agonist dose, if you increase the agonist dose, eventually you will be able to overcome the competitive antagonist. There is a good example here about diazepam, which is an anxiolytic. It's an agonist for its receptor, which is the GABA A receptor, a chloride channel. And a competitive antagonist, which is the antidote, flumazenil. So if you increase the amount of the diazepam, you can basically like decrease the potency of flumazenil, and you can stop its efficacy anymore. So if you increase the diazepam, he will be able to overcome the antagonist. Okay, let's take a look at the non-competitive antagonist. A non-competitive antagonist destroys the receptor. So it binds to the receptor and totally destroy it. If I'm destroying the receptor, what is going to happen to the Vmax? Remember, concentration of the receptor is lower, so the Vmax is going to go down, okay? So the Vmax is going to go down. So this is what they are showing. Non-competitive antagonist binding to its receptor, which is decreasing the Vmax. Vmax is much more lower. Non-competitive antagonist. So non-competitive antagonist, by the potency, there is no change, while the efficacy has less effect. So the remarks, it cannot be overcome by increasing the agonist concentration. So regardless of increasing the agonist concentration, nothing will happen. Why? Because the receptor was destroyed by your drug. Well, what about the other receptor? Did the drug destroy all of the receptor? Not really. So if a drug works on them, can he work? Yes. That's why the potency is untouched. Okay, an example of this is norepinephrine, which is an agonist, and also a drug called phenoxybenzamine, which is used in pheochromocytoma. It's a non-competitive antagonist on the alpha receptor. So this drug it's irreversible. It destroys the receptor, the alpha receptor, which means that the efficacy is going to go down, but the potency will be exactly the same. So partial agonist, it means that they cannot reach the Vmax if given alone, okay? But they work as an agonist. The definition of a partial agonist, it's a drug that when you give it, it works as an agonist if given alone, and work as an antagonist if given with an agonist. Let me explain. If I give a partial agonist such as buprenorphine to a patient, it will be acting as an agonist on the mu receptor, opioid mu receptor. But if you give it with morphine, which is a full agonist, it will start acting as an antagonist. Okay, so potency is independent because of the story I said, and acts at the same site as a full agonist. It leads to decrease in the less efficacy because it's partial, so it will not reach the same Vmax. If the Vmax was normally here, a partial agonist will reach something like this. Okay? So morphine, a full agonist, versus buprenorphine, which is a partial agonist at the opioid mu receptor. We do give our patients sometimes buprenorphine. Why? Because it makes them feel happy, but it's not reaching the Vmax, as you can see. So our addict patient who does a lot of narcotics, we want to keep giving him the narcotics because we don't want him to get withdrawal symptoms, So we give him a buprenorphine, right? Which is a partial agonist, which means it's going to work something like this. Okay, so what about if he tried to trick us and he takes opioid? Well, it's going to be even worse for him. Why? Because the efficacy of the opioid together with the partial agonist, it's going to be lower. Because the partial agonist start acting as an antagonist in the presence of an agonist. What about an inverse agonist? Make a note about this. An inverse agonist is leading to the exact opposite function, and the graph of it looks like this. So this is inverse agonist. Inverse agonist. Okay, let me show you. I hope I will find it. Nice. Okay, you can see here an inverse agonist. Good. So the next thing is therapeutic dose. Back in the time when they used to do, well, still we do it, animal studies, we have something called the therapeutic dose and the effective dose and the death dose or toxic dose. So basically, we need to keep ourselves between two lines, toxicity and efficacy, right? So we want the drug to stay between them, and we call the area between the toxic dose and the infectious dose the therapeutic dose. If you give a dose less than the effective dose, that means the drug will not work at all. If you give an amount more than the toxic dose, you will get some serious side effects that can lead to death. So you need to stick to the therapeutic dose. Okay, measurement of drug safety. So the therapeutic dose, median toxic dose divided by the effective dose, which is the median effective dose. For 50-50, what does that mean? For at least 50% of the people, okay? So what is the median dose, toxic dose for 50% of the people? What is the median effective dose for 50% of the people? Therapeutic window is the range of a drug concentration that can safely and effectively treat the disease. Okay, so they write here the therapeutic dose is the toxic dose for 50% of the people divided by the effective dose of 50% of the people. Safer drugs have higher T1 values. Not T1, therapeutic index. They have higher therapeutic index, which mean much wider range of drug. And this is safer. You will not be so scared about the patient renal function, because if the drug has more therapeutic dose, that means, okay, if you mess up the dose a little bit, it's not a big of a deal. It is still infectious and it's still not toxic. But if your therapeutic index is really narrow and something minor happens, the drug can either become totally useless, not functioning, or becomes toxic. One of the common examples of these, so they write here, low therapeutic index value frequently require monitoring. Yeah, so the drugs with low therapeutic index, you need to check the patient for, how much is his INR today, to check for warfarin, because a minor change can lead to death. Theophylline also are checked, digoxin, anti-epileptic drugs, lithium. So all of these are having really, really low therapeutic index, thus have really high risk of either toxicity or not working at all. Thus, we need to keep monitoring them closely and checking the concentration of the drug in the plasma almost every other day. So the lethal dose often replaces the toxic dose in animal studies, which means the lethal dose is how much of the drug was required to kill 50% of the animals. Okay, how much drug it was needed to kill 50% of the animal. Okay, good. So let's go to the next topic, a drug effect modification. We have drugs that we call their effect to be additive, permissive, synergistic, potentiation, antagonistic, and tachyphylactic. All of these are actually quite important. Let's start with additive. This is quite simple. It's using two drugs different from each other. Why? To get the sum of their effect. For example, it's like when using aspirin and acetaminophen. Keep in mind, aspirin is an NSAID, acetaminophen is not. Acetaminophen works centrally. They have the same efficacy, thus it's 2 plus 2, it's equal to 4. But the idea, why would you do that even? Because, for example, you don't want to use two NSAIDs because they can be nephrotoxic. Okay, so you use a drug that is nephrotoxic, which is aspirin, and one that is hepatotoxic. Thus, you will not have too much harm on one organ. Okay, so that's an additive function. You use different drugs with different mechanism of action to get some form of an effect. The next one is going to be permissive. So permissive, the presence of substance A is required for full effect of substance B, like cortisol on catecholamines responsiveness. Let me explain this one by going back to biochem. In the biochemistry chapter, metabolism, we are going to discuss one graph of phenylalanine metabolism. One of the last steps here is norepinephrine getting converted into epinephrine. For the sake of this conversion to happen, we need a weird name enzyme that you don't have to know, but that enzyme is worked out by cortisol. So if cortisol was not here, the norepinephrine will not come the epinephrine, and thus no epinephrine means no actual function of the epinephrine. Okay, so let's go back here. So yeah, that was permissive effect. Cortisol on catecholamine responsiveness. So synergistic effect, its effect of substance A and substance B together will be greater than the sum of their values individually. So if you give both of the drug together, the sum of their effects will be much more than giving each of them alone. I like to think about it like teamwork. If I'm good and if I have a good colleague, both of us will make a better job for the organization, much more than two of me, because we complete each other. So clopidogrel and aspirin create much more effect than giving the double of the dose of the aspirin, regardless of the fact that they have totally different mechanism of action. So the difference between the additive and the synergistic, the overall efficacy is going to be much higher. So it's like 2 plus 2 is equal to 6. While additive is just like giving the double dose of one of them, but without the side effects. Potentiation, however, is similar to synergism, but one of the drugs, like drug B, has no therapeutic action. It's totally sleeping. So it enhances the therapeutic drug A, however. For example, clopidogrel blocks the enzyme to prevent peripheral conversion to levodopa. What does that even mean? Well, if you go to neurology, and you check this drug. So yeah, if you speak about the carbidopa, it inhibits something called dopa decarboxylase, okay? And it's going to inhibit it. So this dopa decarboxylase normally destroy the L-dopa, and now because the L-dopa is not destroyed anymore, it can go to the CNS. So without carbidopa, L-dopa will be useless. Carbidopa is not working at the dopamine receptor. It's not working there. It's just preventing the degradation of dopa. So the function of carbidopa, which is like a drug B, is 0, while the dopa function is 2. But dopa, which is a drug A, without the drug B, which is carbidopa, is totally useless. Okay, so that is the point there. Okay. So that is potentiation. Antagonistic, it's, for example, the effect of a drug A and the drug B together is less than the sum of them of their individual usage. For example, it's the drug and its antidote. For example, ethanol and fumibazole, which is the antidote of it. Or here they mention ethanol, which is the drinkable alcohol, like tequila, for example, and for methanol, which is the antiseptic. If somebody consumes antiseptic, such as like for the hand antiseptic, and you don't have a nearby fumibazole, which is the drug of choice, what can you do? Well, make him drink ethanol. It is going to compete with the methanol for the same enzyme, which is going to get less effect of both of them giving alone. So yeah, they antagonizes each other. The last one is tachyphylactic, which is a decrease in the responsiveness for a drug after repeated administration. I just imagine it as tolerance. For example, this nose decongestion. If you use it once, it's bad. If you use it once, oh, amazing, I don't have rhinorrhea anymore. Use it again. I don't have rhinorrhea anymore. Keep using it. After 3 days of using it, it will lose its efficacy. So that's tachyphylactic. After repeated usage of a drug, it loses its efficacy. The same idea with hydralazine, nitrates, niacin, and phenylephrine, LSDs, and MDMA, which are basically drugs of abuse. Okay? The last two, I mean. Okay. So that's the main things that you have to know for general pharmacology. In our next class, we'll speak about the autonomic drugs. Until our next class, I have some times now, so I'm thinking that we can discuss a little bit of lab techniques. So I'm going to explain the BCR for now. So the BCR, polymerase chain reaction. The first trick that you have to know that the BCR is made to, well, basically check for the presence or absence of some fragment of DNA, okay? So, for example, it can help us to detect exactly, do we have the DNA of HIV? Do we have the DNA of herpes? Do we have the DNA of that virus or bacteria? So as you can see, it's really useful. So if you do have the gene, that means you do have the disease. If you don't, you don't. Molecular biology lab procedure used to amplify a desired fragment of DNA. So you are just increasing the amount of the DNA. Useful as a diagnostic tool. So for neonatal HIV, also for herpes encephalitis. So as you can see here, we will speak about each step. So the first step is denaturation. We have a double-stranded DNA. For the sake of denaturating them and dividing them into two different strands, we must heat them up. When we heat them up, we destroy this bonds, which is the hydrogen bonds. So the DNA is heated to 95 degrees to separate the strand by destroying the hydrogen bond. And after that, we start the procedure of annealing. The sample is cooled to 55 degrees Celsius. And next we use a DNA primer. A heat-stable DNA polymerase, the TAQ, that's basically a primer, is going to forget about this portion for now. Let's speak about the primer. We add the primer, which is going to attach to the gene of interest. For example, let's say HIV, okay? So it's going to attach at that gene of interest we are looking for. That means each PCR is only responsible for one gene only, okay? So DNA polymerase and deoxynucleotidated trinucleotide. Why are we adding these? Well, these are really useful because one of them is the DNA polymerase, which is going to help in the replication. And if you want to replicate, you need a building blocks, which are the nucleotide. That's why we are adding a nucleotide, as you can see, deoxynucleotide triphosphate. Okay, so the DNA polymerase and the nucleotide will do their jobs, which is the DNA polymerase laying the blocks, and the blocks are the nucleotide. We will build a complementing strand, and after that we will start having this elongation process. The elongation process will start occurring at both of the strand. And notice, you have the double of amount of like the DNA as the first time, right? Okay, what's now? After we have elongated it, we do so by increasing the temperature again, of course. The DNA polymerase attaches to the nucleotide to the strand to replicate the sequence after each primer. As you can see, the DNA polymerase is adding the nucleotide. Okay, so we have a lot of it. What to do next? Repeat the cycle. Just do it all again. Do it all again means initially we had one strand. Now, 2, 4. Keep doing it. From the 4 you get 8, 16, 32, 60, 64, and keep going. Basically, you will have a huge amount of these particles that can be detected. So heating and cooling cycle continues until a fair amount of DNA is sufficient to be able to be detected. Okay, polymerase chain PCR can be used for DNA containing microorganisms, including viruses and bacteria. What about the RNA virus? Will PCR work on them? Will PCR work on an RNA viruses? What do you think? Will PCR work on an RNA virus? Well, here is the thing. Mainly it works on the DNA, thus it cannot work on the RNA virus. So if you have an RNA virus, you have to convert it into DNA. And the DNA virus, then it's going to do normal PCR on it. So for the sake of converting RNA to DNA, you must use a reverse transcriptase, okay, to convert RNA to DNA. Thus, instead of PCR, we call it a reverse PCR. So that's PCR. The next test we are going to speak about is the CRISPR-Cas9. This is interesting. This is cutting edge medicine. Basically, it's the newest thing we have right now. It's, for example, you are going to have a child in the future. Oh, well, you know, they told us in school that person is smart because he's born smart, right? Well, yes, we can improve our smartness, but still, we still get something from our parents. Being intelligent is a gene, basically. You can make yourself get more intelligent, but still, being intelligent is one of our genes. Being tall is one of our genes. Being like able to lose weight quick, being able to gain concepts quick, all of this in our gene. So the question is, can we control that? So the answer is absolutely yes, we can. Well, how can we do that? By the CRISPR-Cas9. So this is a new genetic type of basically machinery that help us to control our gene. So a genome editing tool derived from bacteria, mostly E. coli, okay? So we use the E. coli machinery to alter the gene of interest. Not only human, it can be other animals as well. So wait a second, is it used, not used clinically? Why it's unethical to use it until this day? Will we use it in the future? I think so, but until now, no. So consists of a guide RNA, which is the RNA of interest, which attacks the DNA of interest. So you can see the guide RNA going inside of the Cas9, which is a particle of the CRISPR-Cas9 complex. So this is the DNA of, let's say, a human being, okay? And this is the guide RNA, which is going to attach to the gene of interest. For example, let's say it's the length gene. Well, somebody who's short and all of his family is short, he decided to make his son taller. So we will bring the gene of interest, the guide binding to the gene of interest inside of the Cas9, which we take from E. coli. And now they say we make a single or double cut in the strand at the target site. So this is our target. We have found it by the guide RNA. We make a double-stranded cut in it, like this, okay? And what do we do next? We cut it. So what to do next? Well, do you want to keep it? Or do you want to change it, Or do you want to just throw it away? Well, here is the thing. In this case, after breaking it, you can do one of the two things. For example, if we are about length, you kick out the previous gene, which is for shorty people, and you bring the gene for tall people, and you put it here. So we call this a knock-in gene. So your child is going to be more lengthy. Let's say that we have a family with a recurrent story of cancer because of a BRCA mutation. You bring a guide RNA that attaches to the BRCA gene inside of our genome, which leads to the cancer. And next, we just cut it. Okay, we cut it. What to do next? Screw this gene. I don't want it, and I don't want anything related to it. Okay, that's it. Just reseal it, and you are done. So you reseal it. This is a knockout type of mutation that we have created it. So as you can see, it's a knockout inactivation mutation. So they write here that a break imperfectly repaired by non-homologous enjoining, accidental frame shifting mutation, it's a knockout to kick out the cancer out of the body, cancer gene, Or you can do, bring a donor DNA sequence can be added to fill up the gap using homology-directed repair. So you can use the homology-directed repair to take the DNA of the donor for the length, for example, to add it to the area where you have made the cut to get a son that is much more lengthier. So it's not used clinically. Potential application include removal of virulence factor from pathogens, which is actually was studied to remove the malaria from the Anopheles mosquito, okay? And they thought, okay, we can remove it from a few of the malaria mosquito, and we can make them like mate with another mosquitoes, and we are going to spread a new generation of mosquitoes with no malaria inside of them. So replacing disease-causing alleles of gene with healthy variant, which is like cancer, no cancer type of thing, and targeting tumor cells. So yeah, the CRISPR-Cas9 is the future device of editing our genome. It's unethical. We don't use it yet, but it's just a story about time. It's about the story is when, not if. No, it's when. We will have to use it one day. So blotting procedure, the blotting procedure in general, we have the snowdrops. You must memorize this mnemonic because this is the thing that help you to memorize everything that you need. So what is this snowdrops? We have the snowdrops, which is southern blot, help you to detect DNA. Northern one for RNA, western one for protein. So, okay, sounds interesting. So what about these? Southern blot help us to detect the DNA inside of our body. Most of the time, actually, the questions are straightforward. Just memorize this mnemonic and you will get it. We'll explain how we do it, but this is mostly how they ask the question. So the DNA sampling is enzymatically cleaved into a smaller pieces. So this is actually, guys, how we check. You know this program, maybe you are not the father. This is what they do, Southern blot. They check the DNA of mommy and daddy and the boy, and they check if he's the father or not. Also, they can check if he has a mutation that comes from the father or mother. So they write DNA sample enzymatically cleaved into a smaller pieces, which are separated on a gel electrophoresis. So we bring a gel and we put an electricity on it, positive end, negative end, and we start the electricity. After putting this small particles of gene, and they start spreading on the electrophoresis. Filter is exposed to a radio-labeled DNA probe that recognizes and anneals to its complementary strand, which basically make you a different little subparticles of the DNA according to which probe it's binding to, resulting in a double-stranded labeled piece of DNA that can be visualized when filter is exposed to film, and it would look something like this. So this is a Southern blot. Okay, so what do we see here? So the normal is like people who have, let's say, autosomal recessive disease. Both parents are healthy, but they are carrier, as you can see. If the whole thing is red, that means they are thick. If the dot is in the middle, that means that they are carriers. A circle means a female, a square means a male. A man and a lady got married. They got a daughter that is sick, a boy that is a carrier, and a boy that is healthy. Notice, the small a allele is for, in the genotype, is for sickness. So only the one with two sick alleles do actually have the disease. The other ones are normal, okay? They are carriers, yes, but they are not sick. So notice, this guy do have a mutated allele, but do also have a healthy allele. This guy only have the healthy. This one has both sick and healthy. This one only sick, so he's sick root. She's going to get the actual disease. She's a lady because she's a square. This one is a carrier because he has both the mutant and the normal, and this one is a carrier because it has both the mutant and the normal. So the Southern blot can help us to check for the chance of getting the disease in our children. What about Northern blot? Well, Northern blot is the thing that is similar to the Southern blot, but instead of DNA, snowdrops. It's for the RNA. So just memorize this mnemonic, guys. It will save you a lot of time. Similar to Southern blot, except that an RNA sample is electrophorized, useful for studying mRNA level. So it helps us to check how much is the level of that virus, for example, inside of our body, which are reflective of gene expression. So the Northern blot is really useful to detect the virus titers inside of our body. For example, if somebody has the hepatitis B virus, you can check the titers of the hepatitis B to check how sick is this person. The Western blot sample protein is separated via gel electrophoresis and transferred to a membrane labeled antibodies is used to bind to a relevant protein. So the Western blot is to check for proteins utilizing an antibody, and the main idea of it is to check for antibodies. The Southwest one, southwest, south, well, that was DNA, west, that was a protein. So it's to identify A DNA binding protein, basically a transcription factors, including this transcription factor, the C-gen, the C-phos, which is the leucine zipper motif, a transcription factor, using labeled double-stranded DNA prop that help us to identify the DNA binding protein, which are basically, write a note, transcription factor. Okay, guys, so that's it for now, and I will see you after the break. See you in 10 minutes. Okay, let's move on to flow cytometry. So in flow cytometry, we do have the following. So flow cytometry contains the following. First of all, to do flow cytometry, and what does it mean? It's a really good quantitative, it's for a quantity, not equality, but a quantitative type of measure. So flow cytometry can tell you how many CD4 cells do you have, how many CD3 cells do you have, how many CD8 cells do you have. So it helps you to quantify how much of that type of cell exactly do you have. So flow cytometry, a lab technique to assess the size, the granularity, and the protein expression. So it's important for immunophenotyping of individual cells in a sample. Okay? So cells are tagged with antibodies specific to the surface or intracellular protein. For example, the CD3, the CD4, the CD8. So let's imagine that this is a cell and it's a CD3 and CD8 cell at the same time. So, okay, we make an antibody that is, oh, even better. Okay, let me show you on this one. So this cell has an antibody against it, which is CD3 and CD8. So remember, actually, guys, any T cells is CD3 positive. All of the T cells are CD3 positive. But from the T cells, we do have a CD8 positive and a different CD4 positive. But in general, both of them are CD3 positive. So we can make antibody against that to show us which cell is what. On the antibody from the first side, it's like, okay, so this is the epitope of it, which can attach to the CD8. What about the FC portion? What is on the FC portion? Well, the FC portion, it's a fluorescent light with a specialized light on it, which help us to determine, using a camera, which type of cell it is. Is it a CD4? Is it a CD8? So, they're right. Antibody are then tagged with a unique fluorescent dye on the FC portion. Sample is analyzed one cell at a time by focusing a laser of cells and measuring the light scattered and intensity of the fluorescent. So you put the sample here after you put the antibodies on it. Then a laser will be here and the detector will be here. So the laser will be hitting the label fluorescence light, and the detector will be able to detect it. And according to what is the laser is leading to which type of a scattered light, the detector is going to register and it's going to blot it out for you like this. For the USMLE, you must be comfortable, and even for the real life, to read this table. Well, here they say CD negative, positive. So if it's less than this, it's negative. If it's more than this, it's positive. And the same with the CD3. If it's less than this, it's negative. If it's more than this, it's positive. So if a cell is located here, it's a CD3 negative and it's a CD8 also negative. So it's not a T cell at all. It could be a B cell, but not a T cell for sure. What about the this cell here? Well, this one is a CD3 positive, but it's not a CD8 positive. So it's actually a CD4 cells. Why? Because we know that the CD3 cells are either a CD4 or CD8 cells, right? So if it's for sure not CD8, it's going to be a CD4, okay? Okay, what about the cells right here? So they are both CD3 positive and CD8 positive. So they are positive from both sides, so they are going to be scattered at this location. So they write here, data are plotted on either a histogram or a scattered blot. So in the following illustration, you can see some, so if it was a histogram, it will be one measure. So for example, something like this, right? But if we're speaking about the scattered blot, it's more something like this because you have multiple measures at the same time. So cell in the left lower quadrant, which is this one, it's both CD8 negative and CD3 negative. But the cells at the right lower quadrant, which is this one, is negative for both. Okay? Oops. And yes. Okay, and the cell that is in the left upper quadrant, this one, is a CD3 positive, as you can see, but the CD8 negative. The cells at the right upper quadrant is positive for both, however. So yeah, you must be able to look at this and be able to diagnose it. Commonly used for hematological abnormalities such as leukemia. How many cells do we have? Paroxysmal nectorial hemoglobinuria, because they can help us to check for the GIBA, for the metal gene and the CD55 and 59 type of thing, right? So because they help us to detect these, it makes our job easier for diagnostic paroxysmal nectorial hemoglobinuria, a pathology that we are going to speak about in hematology. Speaking of hematology, guys, please vote on the poll I just posted for me to know which system I should do next. Should I do hematology or should I start with the musculoskeletal system? It's your choice. So the next thing we have here is fetal RBCs in a pregnant lady blood for you to check if there is some type of mixing of the blood. And for immunodeficiency, for example, it helps you to quantify the CD4 count in HIV, which is super, super important. Okay, the next one is microarray. I'm not going to explain it from here because the explanation here is really poor. Instead, I'm going to show you a picture, and that's everything you need to know about microarrays. Microarrays are not high yield, but for the sake of completeness, I must show it to you. So yeah, that's what you need. So, just a second. Okay, good enough. Okay, so the DNA microarray. We have pathological cells and we have healthy cells. So you take them and you put them inside of some culture. You culture them out until you isolate the RNA of interest. And then you do reverse transcription to take the RNA and make a DNA out of it. And then you put a dye on it, okay? And after you put a dye on it, what do? Well, you put it in this microarray. You do this DNA microarray type of shape, and this can help you to identify the tumor cells from the non-tumor cells, or the pathological cells from the non-pathological cells. But in general, this test is utilized only for cancer. It helps you to detect cancer or not cancer. To be totally fair with you guys, we don't use this test that often anymore. It's useless, but it's just like one of the things you have to know for, I don't know why, seriously, it's not used anymore. So no cells are present, it's totally black, there is nothing here, there is nothing labeled. In normal cells only, this is the greenish one. As you see, that was the healthy one, it had the green color. So that will have the green. The red ones, it's the totally cancerous cells, as you can see here, right? And the yellow one, they do have both healthy and cancerous cells inside of the agar. So basically, we take this tagged type of DNAs and we put them on the new culture so they can hit the pathological cells or even the healthy cells, and thus you can determine the ratio between healthy and sick cells inside of the specimen, okay? So this test is not used anymore that often, but still, you need to know everything. It's used in forensics still, otherwise it's not. ELISA, this is super high yield one. ELISA is high yield. So the idea of ELISA that it can help you to detect an antibody or an antigen from the plasma. So they write, immunological test used to detect the presence of either a specific antigen or antibody in a patient blood sample. Okay, so it involved the use of an antibody, specific antibody linked to an enzyme. So let's say that this is a because this is how we do the test. There is different methods, you don't have to know it. There is something called the sandwich method, the direct method, the indirect method. But basically, it's using the antibodies. And let's say you want to detect here, detection involved the using of antibody to an enzyme. Let's say that you want to detect an antigen, okay? So what you do? Well, first of all, oral antibody. Let's say you want to detect an antibody. If you want to detect an antibody, you bring a well, and inside of the well, you put a built-in antigen for the antibody of interest. Let's say that you are interested for the antibody of COVID, okay? So here you put the what? Spikes protein, okay? So you have put the spikes protein inside of the well. Now you bring the plasma of the patient. In the plasma of the patient, you insert it here. The plasma of the patient is going to have the antibody. So the antibody is going to bind to the spikes protein antigen. Good. So now it's connected. So if you try to wash it off, it will not wash off. Now you add an antibody against the, which antibody? Against the antibody of COVID, right? So this is a secondary antibody. Okay, so this is an antibody attaching to an antibody. And the new antibody has an enzyme at the FC portion, which is going to do what? Well, it has this enzyme. Now you, the doctor, is going to add a substrate. This substrate is going to be converted by the enzyme from no color to, for example, yellow color. This is a positive test. I will show you exactly how this happens. So added substrate react with the enzyme, producing a detectable sign. It can have higher sensitivity and specificity, but it's less specific than Western blot. Remember, Western blot. The Western blot was for detection of a protein. It was having much higher sensitivity. That's why until recently it was the test of choice for HIV, not anymore. Often used to screen for HIV infection, but not anymore. We use now the oh yeah, I got you. So used for screening for HIV, they are speaking about the PCR, not the Western blot. That's correct. So we check for the B24. We also check for the antibodies of HIV against HIV 1 and 2. Okay? So now a few things about ELISA. I would like to show you a scheme of it. Okay, so yeah, here you have an antigen. You want to detect it. So this is the primary antibody that you get from the serum, right? Then this is the antibody you put. So you put an antibody against the antibody of the serum, and it has an enzyme into it. Then you add a substrate that is going to be converted to a specific particle that can be detected. And thus, this is a positive sign. So this is the ELISA we are speaking about. As I said, there is the direct, indirect, and the sandwich. You don't have to know this. You just need to know that you can either check an antibody, I mean, you can detect an antibody using it or an antigen using it if you do the sandwich. You don't have to know the sandwich. You just need to know that it helps to detect antibodies and antigen. That's pretty much it. Okay, so the next couple of topics. So this will be the last two topics I explained for today. I told you regarding these two, I will not explain them. I will send you a video if you want, but I will not explain these because myself, I don't feel strong in this topic. So karyotyping. So karyotyping, we utilize something called colchicine. Colchicine, where did we hear this word? Colchicine, colchicine. Anybody know what is colchicine? Colchicine, or colchicine if you want. What is this drug? It inhibits something. What was it? Well, I hope you are thinking about microtubule inhibitor. It leads to microtubule inhibition, which is going to lead to a decreased movement of the spindles, mitotic spindles, which means you will have halting of the chromosome during an exact phase of the cell cycle, which is the metaphase. At the metaphase, we have all of our chromosomes separated in the following fashion. By the way, when you take a look at the chromosomes, this is 1, 2, 3, 4, 5, 6, and all of them. Well, they were not stupid when they have divided them. They divided them according to the length. So 1 is the lengthiest, 22 is the shortest. Notice, the more you go, the shorter they become, right? So yeah, they were subdivided according to the length. Keep in mind that the Y chromosome is the shortest, while X is quite big. So chromosomes are stained, ordered, and numbered according to the morphology, size, arm length ratio, and bending pattern. So arrows. Okay, so here they are saying about the banding pattern. Can you see this notches? These notches can be in cases of cancer, and we'll speak about why they are occurring. As you can see here. It's because of some forms of translocation. It's really difficult to see them in normal karyotyping. It's much easier to see them using a fluorescence in situ hybridization, also known as FISH. So using FISH is much more easier to see translocations. Okay, anyway, so it can be performed on a blood sample, bone marrow, amniotic fluid, placental tissue, anything with a human tissue in it. Used to diagnose chromosomal abnormalities like autosomal trisomy, Down syndrome, Batau, Edwards syndrome, or sex chromosomal disorder, an XXY, an XYY. Well, for XO, like for example, Turner syndrome, Klinefelter syndrome. As you can see, this patient has a trisomy 5, it has a quadrisomy 8, and what else he has? What other problems? Let's see. Okay. Probably he has a little translocation here, but as I said before, translocation are really bad to see in cases of karyotyping, but easily you can see them in fish. So if you have, let's say, one more here, this is trisomy 21, 3 chromosome of 21. This is Down syndrome. If it was 18, something like this, it is going to be trisomy 18. This is going to be Edward. If it's going to be here, it's going to be trisomy 13 Batau. If there is no X chromosome and only one, no Y chromosome and only one X chromosome, this is 45XO, this is Turner, okay? So this is karyotyping is really helpful in detecting 6 chromosomal abnormalities and autosomal trisomies. So, fish. Fluorescent DNA or RNA probe binding to a specific gene site of interest on the chromosomes. So we bind to many genes on the basically the chromosomes, and they can just light up all of our genes, as you can see. This is good. This is much more easy to find abnormalities here. So arrows in A point to abnormalities in cancer cells. So you can see here, yeah, you can see there is some form of, like, you should have only 2. Why there is a 3? This is abnormal, okay? So used to specific localization of gene and direct visualization of chromosomal abnormalities at the molecular level. For example, microdeletion, an absence of one portion of the chromosome. So no fluorescent on a chromosome compared to a fluorescent at the same locus on the second copy of this chromosome. Okay, let me take a look here. I cannot find an actual one, but let's say that oh well, maybe here a little bit, but if this whole thing was not here, for example, we can say that this is a microdeletion on chromosome number 15, for example, you know? While a translocation, which is the most easily seen one, for example, look, 17 is pink, 19 is a green. But wait a second, why there is something pink on it? Because there was a translocation, okay? So genomic translocation between chromosome 17 and 19 has occurred. Translocation of fluorescent signals that correspond to one chromosome, pink, is found in a different chromosome, green. So the 2 white arrows in this one, are showing fragments of chromosome 17, pink, that are having this translocated into chromosome 19, the green one. So this is a translocation. Remember, so many cancers, hematological cancers, are a translocation that we are going to speak about in hematology. Well, we will see which subject we'll do next. So far, hematology. We'll see what other people say. Duplication, a second copy of a chromosome resulting in a trisomy or tetrasomy. 2 blue arrows duplicate at the chromosome 8. Oh yeah, this is a quadrosomy, right? Which means tetrasomy, which means we have 4 chromosomes. What else do we have here? Yeah, so here we have 4 chromosomes. As I said before, if you have a third one here, this is down, Batau. sorry, Edward, Patel. If this is absent, it's Turner. If there is another Y chromosome, this is XYY, which is the patient just become more aggressive. A man that is really aggressive, XYY. Okay, good. So that's lab technique. In the next class, we will try to finish more pharmacology. We just finished the horrible portion of it. Now the next portion actually becomes quite more useful clinically and quite more interesting. So after pharmacology is done, please vote on the thing we put so we can decide what to do next. Is it musculoskeletal or is it hematology? I prefer hematology, but you can choose whatever you want. So see you guys next time.